First up is going to be cancer, importance of early detection. I have with us today Dr. Mark Fleming, who is both a dear friend, church member. He's with Virginia Oncology, and he and I, we have these discussions. We always talk about how much we work, and he'll text me and he'll joke with me and saying he knows it's like 10 o'clock. He said, I'm doing Keep Newbie hours tonight. And I'm texting him right back, because this is what we do, but we share information with each other, that which is going to help the community. So we are fully engaged, as he has been for the last several years that he's been in the area. So I wanted to take no further ado to introduce Dr. Mark Fleming.
Good morning. We had a little technical difficulty this morning, and my presentation wasn't able to be hooked up, but I think we can work with it. So if you forgive me, I'm used to kind of working off PowerPoint slides to keep me organized. So what I want to talk about today is really the early detection of cancer. And I kind of have a sub-expertise in cancer care. I am a GU medical oncologist. I see lots of prostate cancer, bladder cancer, kidney cancer, and testicular cancer. And when we think of the diseases that we can prevent, there are several cancers that we can prevent, and it's really because of early detection. When I say kind of prevent cancer, that we can find it at a stage where it is curable. Some cancers are inherited. Most cancers have to do people's lifestyles from that perspective. So let's start with the first one, the biggest one. Does anyone know what's the biggest killer of cancer patients in the U.S.? This is an open discussion. I couldn't hear you. Lung cancer. So let's talk about lung cancer. Lung cancer is highly, highly, highly preventable. The biggest thing one can do to prevent a lung cancer is don't smoke. And the second thing you do, if you do smoke, is stop smoking. So smoking is a lifestyle. If you modify your lifestyle, you can prevent the majority of lung cancers, because the majority of lung cancers happen as a result of smoking. There are some, mesothelioma in particular, that can happen as a result of occupational exposure, and you can just watch TV. I watch Judge Judy when I'm not texting Dr. Newby about working hard. And you can see all the commercials about call 1-800-LAWYER if you've been exposed to asbestos and you have mesothelioma. But the majority of lung cancers, and the more people die in the United States of lung cancer than any other cancer. So what do you do if you are a smoker or you were a smoker? Well, we now know that if you smoked more than 30 pack years, that's how we kind of look at the risk of lung cancer, is what's called pack years. So it is different if you smoke 1 cigarette a day or 1 cigarette in your lifetime. I think when I was 18 or 19 years old, I went off to college and I experimented. I experimented with a cigarette and it wasn't for me. So my pack year, I do not have a pack year history because I smoked 1 cigarette in my lifetime. Didn't like it, wasn't for me. But you really can look out how many packs a day someone smokes. So if someone smokes 2 packs a day for 15 years, they have a 30-pack year of smoking. And anything greater than 30-pack years of smoking, we have shown that the early detection of lung cancer is beneficial. And that's with a test called a CT scan. It's a low-dose CT scan where you go into a machine and they take a picture of your lungs. They recommend that yearly for someone who has been exposed, who has greater than 30-pack year history of smoking. So what can you do? You can not smoke. You can, if you do smoke, you can stop smoking, because if we look at people who used to smoke and they stop smoking, over time the risk of smoking returns after about 5 years to a normal person's level. So it's very important to talk to your loved ones in terms of stopping smoking. Primary care physicians are excellent at, there are multiple medications, there's lifestyle modifications in order to stop smoking. So I wanted to touch upon that. breast cancer. As I look around the room, the majority of the women I see are over the age of 40 years of age. And if that is the case, then you should have had a mammogram at this point in your life. At age 40, at a minimum, you should be getting a baseline mammogram. If you have not got a mammogram, then you should. If you should talk to a loved one, if they haven't had a mammogram, that they should, because breast cancer, when detected early, is usually a curable condition. My mother had breast cancer. She got yearly mammograms, and it was detected early, and she is now cancer-free, now greater than 10 years. And so, yes, did she require treatment? Yes. Did she require surgery? Yes. Did she actually require chemotherapy? She did, but because of her early detection of her breast cancer, she was able to meet her grandchildren, most importantly, her youngest grandchild, Colin. And so that's why that's why early detection is important, because don't just think of yourself because people are afraid. I have seen breast cancer masses as the size of a grapefruit, okay, that the patient knew, family likely knew, but because they were afraid, they didn't get tested. In fact, I had a woman whose breast mass got so big that her breast fell off because it got necrotic and it smelled. And that doesn't happen over weeks. That doesn't happen over months. That happened over years of just neglect, of not wanting to address it. So we have to have those tough conversations with our family members, not to be afraid, and doctors are here to help you. So for breast cancer, you should be getting a mammogram at least yearly, age 40, some people will say 45, if you have a strong family history. And so for African American women, there is a special type of breast cancer. Well, it's not unique to African American women, but what's called triple negative breast cancer. Triple negative breast cancer is highly aggressive. And so if you have a loved one who's been detected with the cancer at an early age, or an early age is less than the age of 40, a simple rule is subtract 10. So if you have a family member who got diagnosed with a breast cancer at age 36, then her loved ones in her life should be getting mammograms at an early age. And in fact, there are other tests called a breast MRI that they can get to help prevent that disease. So you get a mammogram yearly. They're very good about reminding you to get yearly mammograms, and as you get older, it might spread out over time. So we've talked about lung cancer, we've talked about breast cancer. I don't have enough time to talk about treatments. I'm sure I might get some questions. Another cancer I want to talk about is prostate cancer. I see lots of prostate cancer, and some would say that I'm a, quote, prostate cancer expert. And my hero is my father, and I actually lost my father to prostate cancer. So what's controversial about prostate cancer is it's unclear in terms of the guidelines when you should start and who should start it. Well, this is Mark Fleming's recommendations regarding the early detection of prostate cancer. If Dr. Newby had asked me, Dr. Fleming, let's do some prostate cancer screening, I would have said, Dr. Newby, I don't believe in prostate cancer screening. And he would have taken a step back, and usually I do whatever Dr. Newby asks me to do. However, prostate cancer screening is taking a random population of patients, and you give them what's called a blood test called a PSA test. And I would have said, no, Dr. Newby, I do not believe in doing a random population of patients and checking a PSA. I would say yes to Dr. Newby if he says we could have an educational session about the importance of prostate cancer. You allow us to do a digital rectal exam. A digital rectal exam is where an exam where a doctor takes a gloved finger, lubricated, and is able to feel a prostate on a man. And then I would say, if we also are able to do PSA testing, then Dr. Newby, I would be willing to do that type of testing. So I don't believe in screening, because screening is a random group of patients, but I do believe in an informed group of patients understanding the risks and benefits of treatment. And let me tell you why. Well, prostate cancer can be aggressive, especially in African American men. The American Cancer Society advocates you having a discussion before you getting a blood test as well as that digital rectal exam. I have had 89-year-old men come to me with a history of congestive heart failure. They're seen by Dr. Newby. They're on dialysis, and their loved one heard a talk about prostate cancer screening, and they wheel him in a wheelchair, and they say, well, let's test his PSA. Well, the reality in that situation, in an 89-year-old who comes in with congestive heart failure, with end-stage renal disease in a wheelchair, his prostate cancer, if diagnosed, is not going to be his major issue. And so you always have to balance the age, the other factors from that standpoint. So what you did not hear me say is, Dr. Fleming says, don't test an 89-year-old. What I said was, you have to look at each situation in particular. For African Americans, at age 40, I think it is a reasonable, appropriate time to begin the early detection of prostate cancer, which means a digital rectal exam, a PSA blood test, and information about the risks and benefits of a positive test. Because the only way you can detect prostate cancer is with a biopsy, which can be an uncomfortable procedure, but necessary. So we've talked about breast cancer, we've talked about lung cancer, we've talked about prostate cancer. Colon cancer is probably the most preventable with our screening tests, and how you detect the early detection of colorectal cancer is through either a colonoscopy, a test where you test the stool, you've seen the commercials on TV, and kind of knowing your body. And so I've stood in Fort Norfolk, and hopefully the United Methodist lets me do not Fort Norfolk, excuse me, First Baptist Church. I don't have a mic, but everyone, we all have to go to the bathroom, and when we go to the bathroom, we should take a look behind. Because if you take a look behind, you can see if there's any blood in your stool. Blood in your stool is never a normal thing. And so if you ever see blood in your stool, you should be evaluated by a physician. If you ever have blood in your urine, be it a male or a female, that can be an early detection of bladder cancer or kidney cancer. So blood is not normal, especially in a male. Why do I say especially in a male? Well, women have menstrual cycles, and depending upon your age, they can potentially see some blood in your urine. But a woman who has stopped menstruating, typically around the age of 50, you having vaginal bleeding or blood in your urine is not normal. We hear this all the time. So I'm a cancer doctor. What I do is I take care of patients with typically advanced disease, and I manage treatment. I hear all the time, well, Mr. Jones, when did you first know something was going on? Well, last Thanksgiving, I noticed some blood in my urine. What did you do? Well, it went away. Okay. Then it came back in Christmas, but the grandkids were there and I didn't want to do anything about it. We hear this all the time. Blood is not a normal thing. So, prostate cancer. So, unfortunately, there are no, quote, screening tests for bladder cancer or kidney cancer. What you can do, your doctor at least yearly should be checking a urine sample on you, and they can detect if you have any microscopic urine. Let's get back to colon cancer. So there is no clear screening tests or early detection beyond education of bladder and kidney cancer. But for colon cancer, there is. So everyone's going to go, after today, they're going to turn around and make sure they don't see anything like that. Because I have a 6-year-old and I know he turns around, and everyone here should be looking around. Well, colon cancer is very important. We did that very thing, and a dear friend, as a result of our early detection program at First Baptist Church, got his first colonoscopy. And when he got his first colonoscopy, he found his colon cancer. And so he is now cured of the disease at this point in time. It's a wonderful thing that he did not need to see me and have to get any treatment from that perspective. Treatment beyond surgery. Colon cancer. Oh, important thing about colon cancer. So I turned 50 last year. And I was getting together with some friends, and we were talking about some health issues. And I said, Mike, so how did your colonoscopy turn out? He says, I don't need a colonoscopy. I said, you're 50 years old. You need a colonoscopy. Well, you should have had one at 45. He said, I didn't hear that. Well, many people in this room are African American, and African Americans should begin colorectal cancer screening at age 45. I believe in colonoscopies because they can look at the whole tract. There are some other tests, but the most, quote, difficult thing about a colonoscopy is the prep. You need to prep. You have to go to the bathroom and you get kind of clean your belly out. But you should be either doing that fecal occult testing, checking your stools, send it to your doctor. Colonoscopy, there's also a CT scan that you can get as well. But you should start, African Americans should start at age 45, 40 for prostate cancer early detection. For whites, it is age 50 for colon cancer screening, and for prostate cancer early detection, the same. If you have a family history, usually subtract 10 years. So, if you have a family member who was diagnosed at age 44, when I say family member, first degree relative, mom, dad, sister, brother, children. If they get diagnosed at age 36, you subtract 10 years. They get diagnosed, and whatever comes first. And so 45 for African Americans. Well, it happens. We don't know why, but African Americans tend to have colon cancer a little earlier, and you need to test for it. There's genetic testing, so if you have a strong family history in your family of cancer, I know we, Virginia Oncology, we have genetic testing. I know EVMS has genetic testing. That's important if you have a family history to get some genetic testing. It will be covered by most insurances from that perspective. Colon, lung, cervical cancer. So my dear mother-in-law is 86 years old. And I think the usual thing is when you go to the doctor, part of female health for many years was getting a female exam to look for cervical cancer. Above the age of 65, if you have had negative pap smears for 10 years prior to, you can stop getting screened for cervical cancer. Well, people like to feel good that, hey, I'm making sure, but the likelihood of someone getting cervical cancer if they've had negative Pap smears 10 years prior, and they're above the age of 65, that's one of the things that you can stop. It also depends upon when do you stop doing testing. Well, it depends upon how old you are, your other health issues. And so there's no right or wrong answer from that perspective. How am I doing on time here? 5 minutes. Let me just talk about the advances in cancer care briefly. So we've made lots of advancements in cancer care. For example, immunotherapy. Immunotherapy is different than chemotherapy. So when I decided to be a doctor and I decided not to be a cardiologist, I decided to be an oncologist. I'm a doctor who's trained who can safely administer chemotherapy. Now there are drugs called immunotherapy, which allows our immune system to work better. How it works is this: cancer cells have the ability to shut off our immune system. What these medicines do is block the immune system from being shut off, allowing our immune system to work. We've seen some very dramatic examples. I'm very proud to say that I was involved with a drug getting approved for bladder cancer, and I have a gentleman who has been seeing me for 2.5 years. He had advanced metastatic or stage 4 bladder cancer. The typical or median survival of that is about 9 months. And 2 years later, 2.5 years later, his most biggest inconvenience is that he has to drive from North Carolina every 3 weeks to see me, because now when we check pictures, we can't find any cancer. Is that the usual scenario? No. But do we see it? Absolutely yes. And so cancer care is we're making lots of advancements, and I'm a huge, big believer in clinical trials. If he had not participated in this clinical trial, he would not be alive today. But now, and the nice thing is, he gets free drug because it was on the clinical trial, and so he, like I said, his biggest inconvenience, he has to drive from North Carolina to here. Someone will ask me the question about proton therapy, because I always get asked the question about proton therapy. I referred them their very first patient, and so proton therapy is not a new treatment. Proton therapy has been around for many years. I'm going to close with this analogy. So I am a scientist. Is that my sign that I'm almost done? I am a scientist, and let me give you this analogy. If I was to ask you, if I was to take 100 people and ask them what's the best pizza, and I take 100 people who walk into Pizza Hut, and 91% of the people who walk into Pizza Hut say, that's the best pizza. This half of the room says, no, Dr. Fleming. This half of the room, 100 people over here say, I like Papa John's. And 94% of the people who walked into Papa John's say it's the best pizza. Well, the people in the back, the 100 people who walked in the room, go to Chinello's Pizza. And of those people who went to Chinello's Pizza, 86% of the people said it's the best pizza. My question to you, based upon what I just told you, which is the best pizza? Ma'am, what would you say?
I like Domino's.
She likes Domino's. Could you tell me which one's the best pizza?
Papa John.
Papa John's. Well, that's what most people think, because they heard 94%. Well, you can't answer that question, because you took a biased group of people who walked into their Pizza Hut where they already went to. So I get the question all the time. It's about an hour-long conversation. I see lots of people with new diagnosis of prostate cancer. What's the best treatment? Well, we've never compared surgery versus standard radiation versus proton therapy. So it's the same analogy. So you can't compare different things unless you randomly choose. And then I get, Dr. Fleming, what is really I know? What would you do for yourself? I would tell you the same thing. There's no best answer. They're all good options. And so what I leave people with, instead of walking out of here, this is the best treatment, walking out of here with, you go out there, you have these options, go pick the best car, go pick a Lexus, go pick a Tesla. That's an inside joke. Or a Mercedes, and make your healthcare decision that you have very good options as opposed to what's the best option. Because usually there is not a, quote, best option unless there has been a clinical study to answer that. I'm going to close here and answer questions. Thank you.
Thank you, Dr. Fleming. Give everybody a round of applause. So, questions. I want to, we won't stay on time, so let's go ahead and start asking some questions. Let's start here first.
What about the camera pill? How does that help in diagnosing different diseases? The camera pill that you swallow.
Camera pill.
So the camera pill is typically used for, this is a typical scenario. So someone comes to me, they're anemic. We're trying to find the source of their bleeding because the most common cause of anemia in someone who's over the age of 50, 55 is some type of bleeding going on the gastrointestinal tract. The first test usually is a colonoscopy or an endoscopy, depending upon that type of bleeding. But if those are negative, we've seen the colon and we've seen the stomach, but we haven't seen the small intestines, or in this audience I can say we haven't seen the chitlins yet. And so the only way to see the chitlins, the small intestines, is to be able to do a small bowel, the camera where you swallow that. That's the typical scenario. And we don't have any, it's a difficult, only specialized centers can do actually taking a look inside the small intestines with an instrument. So that's the typical scenario where that is used.
Thank you. How can you do genetic testing when you have no brothers, sisters, or other living biological relatives?
Well, then the question I would ask, what would be the benefit of doing genetic testing? So my style is, if you do a test, what are you going to use with that information? Okay, so if we take a 70-year-old person who has no family relatives, we can do testing on that individual. There are some situation is very highly specific where it might be beneficial to know specifically for their cancer. We are able to do some genetic testing, or what we call genomic testing, when someone has an active cancer, and we can find out the best way to treat that active cancer. If someone wanted to do genetic testing on themselves and having no family members, and they were going to use that information, say for example, I'd be willing to go through a mastectomy, remove my breast or my ovaries if I have an aggressive cancer gene. That would be the situation we would do it. But I would think through that first before I do it, because it can have broad implications upon your insurance.
I got time for one last question.
I'd like to know if cranberry juice is a preventive for prostate cancer. Is this something that's beneficial?
I'm so mad at these technology guys, because I have a slide that deals exactly with that. And so I have a slide that looks at studies that looked over 30,000, 40,000 individuals in terms of drugs that have been shown to decrease the risk of prostate cancer. I have a slide that talks about pomegranate juice. There's a study of 48 men who drink 8 ounces of pomegranate juice a day, and it showed that when you do that, it decreases your PSA. It didn't say anything about preventing prostate cancer or treating prostate cancer, but as a result of that 48-person study, when I first came to town, I would say about 25% of my patients were taking some type of pomegranate or cranberry juice extract, And since I'm a scientist, until you show me a study that shows in humans that by taking cranberry juice that it decreases prostate cancer, I would say prostate cancer doesn't hurt. I would talk to your cardiologist, Dr. Newby, if he says it's fine for you to take cranberry juice. I wouldn't be against it, but I wouldn't be saying that it's preventing your prostate cancer.
Okay, we got one more here.
Dr. Fleming, you did not address it, but would you address the issue of multiple myeloma?
Multiple myeloma is a cancer of the bone marrow. Our bodies, all of us make antibodies, and the cells that make antibodies in our bodies are called plasma cells. So multiple myeloma is a disease that is a bone marrow cancer or a leukemia-like cancer that in some situations is curable, typically with what we call a stem cell transplant, but is typically treated with multiple new agents that we have available. Multiple myeloma has changed dramatically since I've been an oncologist, that we're coming up with more and more advances from that perspective. So there are multiple new treatments. I usually start with people, are they transplant eligible or transplant ineligible? That means that how older you are and how many other medical issues that you have. Typically 70 is the cutoff for being a transplant candidate, and that's what's called a stem cell transplant. How do you detect any type of blood cancers? It's usually through blood work. That's why it's important to see your primary care physician and trending out your blood work over a period of time.
All right, thank you very much. Thank you, Dr. Fleming.
Thank you.
All right, thank you, Dr. Fleming, again. And Dr. Fleming, if you can, on your way out, young lady all the way in the back had one question, so if you could talk to her before she left. Thank you.